Good evening, everyone, and welcome to tonight's Cancer Chatters webinar. Can we use the wound healing immune response to treat sarcoma after surgery? My name is Melanie Epstein, and I am the manager of the research funding program here at Cancer Council WA. To begin with, in the spirit of deepening relationships, I'd like to acknowledge the traditional custodians and owners of the land, the Whadjuk people from the Noongar Nation, and recognise their continuing connection to land, waters and community. I also pay my respect to their elders and extend that respect to all Aboriginal peoples living and working in this area. Just before we begin, I'll just start with some housekeeping. I encourage you to ask questions. You can submit your questions via the question and answer function at the bottom of your screen anytime throughout the presentation, and they will be addressed at the end of the presentation. An online evaluation survey will be sent around after the event. I do encourage you to complete this so we can continue to improve the education events that we provide. So tonight, our guest speaker is Dr. Rachael Zemek. Rachael is a postdoctoral researcher within the sarcoma research team at the Telethon Kids Institute. She graduated from her PhD from UWA in 2019. Rachael is now extending her research to target childhood cancers such as sarcoma, which is resistant to immune therapies. Rachael's research will explore how surgery to remove cancer creates a local immune response and develop ways to manipulate this immune response to kill remaining cancer cells. I now welcome Rachael to take over.
Thanks, Melanie. That was a kind introduction. And thanks everyone for joining me this evening. This is the first time I've done one of these webinars, so I'm quite excited to share some groundbreaking research that I'm working on, which I personally find very exciting. So I hope you will enjoy it too. So I titled this talk, Can we use the wound healing immune response to treat sarcoma after surgery? But what I probably should have called it is something more like the immune cells, the cancer cells and the wound. So there's multiple players in this kind of game, and I want to know what's going on, who's talking to who, bit of a whodunit kind of situation. So a little bit about me and what I'm doing. As Melanie said, I finished my PhD in 2019, and since then I've been working at the Telethon Kids Institute, focusing on children's cancers, and I'm currently in the Telethon Kids Cancer Centre. And I just found out today that they decided to launch a Twitter account. So if you would like to go follow them, you may. And this is the awesome team that I work with. So this is the team dedicated to sarcoma research. So we have on the left, Dat, our research assistant, Brianna, our PhD student, Joost, the lab head, Ben, one of our new postdocs who's joined last year, myself, Francois, another PhD student, and Tao, another postdoc who recently joined a month or two ago. So our team only began about 3 years ago. It was just Joost and I, and we've grown quite rapidly since then. And what we do is we want to address high relapse rate with sarcoma, which I'll get to in a moment. So for those who are unaware of what sarcoma is a cancer of connective tissue. So this can include muscle, fat, bone, even cartilage, and is usually in two broad categories, your hard and your soft, so your bone or your soft tissue sarcomas. So your bone sarcomas would be things like osteosarcoma and Ewing sarcoma, while soft tissue sarcoma, they're, depending on where you read, there's varying between 20 to over 100 different subtypes, because it can arise from so many different tissue types. So that can be things like lymph vessels and also the nerves, and they can arise anywhere within the body. So sarcomas are quite rare in adults, and they make up about 1% of all adult cancers, but they're more common in children and young adults, and they can make up to 15% of all childhood cancers. So it's mainly known as cancer of children, and it's unfortunately quite an aggressive cancer. So the way that sarcoma is usually treated is by surgery, and that's to remove as much of the cancer as possible. And then that's usually followed by chemotherapy. So depending on the type of cancer, chemotherapy may be before or after the surgery. But unfortunately, despite having surgery and chemotherapy in very, very high dose, and then even maybe radiotherapy on top of that, up to 40% of patients still have relapse at that local site. So once the relapse does occur, the chances of beating that cancer then drops. So ultimately, at that point where the surgeon is removing that tumour, it is crucial that the surgeon removes all of the cancer. And if they don't, the outcome looks quite dismal. But unfortunately with sarcoma, it's quite an invasive cancer. So it can grow in places where it's hard to reach, or the surgeon can't actually remove all the cancer because it's next to a major blood vessel or near the heart or something. And then it's also quite sneaky. So the surgeon may think that they have removed all the cancer, but in fact, a little bit remains behind. So I'm next going to give a very, very, very brief history of the surgery for cancer. So a lot of people don't know this, but surgery for cancer goes all the way back to ancient Egyptian times. There is this scripture, the Eden Smith Papyrus, which is the oldest known writing that documents both surgery and cancer. So this was named after Edwin Smith, the guy who bought the papyrus, but it actually documents treating cancers, mainly breast cancers, by surgical methods. But back then, surgical methods was quite barbaric. They didn't really have the tools. They didn't know about bacteria, and they didn't know really what cancer was at all. If we go a little bit further forward to modern day, this is still around 400 BC, when Hippocrates was alive. He's also known as the father of medicine because he documented many cases of ailments and ways to treat them. And he was the first to describe the difference between a tumour that is malignant and one that is benign. And he noticed that in some of these cancers that were malignant and were going to kill the patient, they had these kind of protrusions, and they kind of branched out and kind of remind him of the legs of a crab. And then that's how we got the name carcinos, which means crab in Greek, which the word cancer is now derived from. If we then fast forward to the 1800s, so this is quite a big gap. We're going from about 400 BC to the 1800s, and nothing has really changed for the treatment of cancer. Still, surgery is your best hope. However, up until that point, surgery would also highly have the chance to kill you because they didn't know about bacterial infections and sepsis. And it wasn't until the 1800s they figured out aseptic techniques, so techniques to minimize the amount of bacterial infection from surgery. And so surgery wasn't really performed until after this time, where they could then do surgery a little bit more safely, and the surgery itself wasn't going to kill you. So we're now only up to here in the 1800s. This is the point where surgery then became more mainstream. And it wasn't until the 1890s when a guy by the name of William Coley, who also was a surgeon, decided he wanted to do more for his sarcoma patients. So he was a sarcoma surgeon. He first started out with the bone sarcomas, but then ended up treating a variety of cancers. And he saw one patient who had a sarcoma on the face, and he came in to get that surgically removed. It grew back, he got it surgically removed again, it came back, and it just kept coming back, and so he was deemed incurable. Until one final time he got the tumour removed, he got a severe infection. And after that infection had gone throughout to the side of his face and started ulcerating, by the time that they decided to then go back and remove anything that was left, there was no cancer left to find. So it seemed that the infection had helped him fight off the cancer that he had grown on his face. Now, we can't say for sure what kind of cancer he had back then, but it gave him an idea that perhaps you could stimulate your immune system to kill cancer cells. So he first started giving his patients bacteria that was alive, and that didn't go very well because kind of made them very, very sick and may have led to some of their early deaths. But then he decided to make more of a vaccine approach where he gave dead bacteria to patients. And then he would then inject this into their sarcomas. And he said that he observed shrinkage of tumours and in some cases, no detectable disease. Well, back then, detectable disease couldn't really see it by eye. So he was claiming to cure people with this toxin. And so he did make it kind of wide stream that you could buy it and other people could give it. And it was suggested to be given after you've done surgery for your sarcoma. But a lot of doctors didn't see the same results, and there was definitely mixed results. So it didn't really make sense why it worked for some people, didn't really work for other people. And it was kind of, some people really embraced the therapy, whilst other people didn't want to believe him and said it was just like old-fashioned Stone Age medicine. And then that actually did start to take off, and it was becoming more and more popular until we get to the 1940s with the emergence of chemotherapy. So chemotherapy was discovered while they were trying to find therapeutic uses for cytotoxic agents used in chemical warfare during World War II. And they found that a particular chemotherapeutic could start curing children of their leukemia. And then it wasn't until the 1960s that they then found that it could be used for breast cancer. And it wasn't until 1968 they decided that perhaps you should do surgery first and then give chemotherapy to remove any kind of remaining tumour. And then that improved the survival greatly for women with breast cancer. And so throughout most of the 1900s, chemotherapy was the main treatment option, and immunotherapy really got forgotten about. And so it wasn't until the 1990s. So here we have about a 100-year gap between the 1890s with Colles toxins and 1990s emergence of more modern immune therapies. And a lot of that was because these immune therapies were looked down upon as Stone Age and barbaric medicine. So we didn't really understand the immune system very well back then. And so stimulating the immune system was kind of seemed petty compared to these fancy drugs that you could synthesize in a lab. But still, some people saw that there was some benefit, so they pushed on. And so in the 90s, things like the BCG vaccine was approved for bladder cancer. Things like interferon and interleukin, which boost your immune system, were given to melanoma patients. And for some patients had very, very good responses. But what these do is they have the same symptoms of having very severe flu. And so being on these medications for a very long time was really, really horrible, and also led to depression. And in some cases, the patients, they said they would rather die of their cancer than go back on this therapy. So they did start to also fade out of favour as well. And then it wasn't until 2010 was the emergence of immune checkpoint inhibitors. So these are drugs that target the immune cells directly and activate them and make them a bit more angry and more, they want to kill the immune, they want to then go on and kill any cancer cell. And so in 2019 was the Nobel Prize to Jim Allison for discovery of anti-CTLA-4, and then subsequently the development of antibodies against that molecule, which could then lead to cures in melanoma patients. So ever since then, 2010 was the very first results. Immunotherapy has been a very, very big field for cancer research, and it is now overtaking chemotherapy for some cancers, such as melanoma. So for melanoma, frontline therapy is now immunotherapy rather than chemotherapy. But immunotherapy comes at the cost that it works or it doesn't. And so some patients may see spectacular results, and they may have their tumour completely disappear, whilst for some patients they may have no response at all. And so that's a bit of a gamble. So if you're a doctor and you want to give your patient the best outcome, that may not be immunotherapy. So something like chemotherapy, although it does have toxic side effects, is always going to work, is always going to target those cancer cells and going to cause the cancer to die. So a question I get asked a lot is, how can the immune system actually see cancer? And this is because of the mutations in the DNA of the cancer. So most people know that cancer arises due to mutations in their DNA. And those mutations lead to the proteins in the cell also having mutations. And then what happens inside the cell is that little parts of it gets put on the cell surface. And then there's a mutated protein on the surface of the cancer cells. And then your immune cells can come along and see what is on the surface of those cells and kind of see if it's normal or if it's mutated. And if it's mutated, then the immune cell will recognize that as something that shouldn't be there and something that perhaps it should kill. So the immune therapies that we currently have available is things like immune stimulants. So we kind of activate these immune cells a bit more. Cancer vaccines. So we find those mutated proteins and we give a lot in a vaccine form. Adoptive cell therapy, where you actually take out patient's immune cells and you grow them up so there's lots and lots of them and then give them back to the patient. Things like targeted antibodies. So you put an antibody that targets the cancer and then your immune cells will then come along and eat that cell. There's also things like virus therapy, where a virus then infects the cancer cell and then your immune cell will then come along and kill that cell because it's virally infected. But the one that's worked the best to date is known as immune checkpoint therapy. And these are the ones that actually act on the communication between the cancer cell and the immune cell. So cancer cells put on a stop signal saying, please don't kill me, I'm part of you. And so your immune system gets a little bit confused. It's like you can see that it's mutated, but it's also part of you and it's not sure what to do. So this therapy just blocks any signal that says, don't eat me. And then so the immune system will then go ahead and kill that cancer. But I can talk about that until the cows come home. That's what I did my PhD on. But I want to tell you about something a bit more new and a bit more modern. So can we use these immune therapies for sarcoma is the big question. So we can see that in some cancers, such as melanoma, we can get complete responses. So there's been a handful of patients where their cancer has completely disappeared and hasn't come back. And that's amazing. But then when we've tried these therapies with sarcoma, where some trials have shown no effect whatsoever, some report that up to a quarter of their patients had some shrinkage of their tumour, and very, very rarely is there any complete response, so where the tumour has completely disappeared. And the reason for this is because some tumours, when we look at them under the microscope, we can see that they are full of immune cells. And these are cancers like melanoma, for example, are full of immune cells, and they respond really well to immune therapies. Sarcoma, on the other hand, doesn't usually have that many immune cells within the tumour. There's usually maybe a few around the edge. And then this seems to be why some are going to respond better and some aren't. So my question was, can we use surgery to improve the response to immune therapies? And the reason I asked this question is because when you do surgery, you're not only removing a tumour, but you're also invoking an immune response. So if you think back to caveman times, so here we have our caveman and he's, I don't know, being bitten by a tiger. The only thing that's going to keep him alive is his response to, first of all, stop the bleeding, so his platelets need to clot, and second of all, for his immune cells to kill any bacteria that got in. So if his immune cells aren't recruited to this wound site, any bacteria that got in is going to get into his bloodstream and then kill him. So as soon as you have any sort of wound, your immune cells are attracted to that area. So my question is, can these immune cells that come into that area also kill cancer? So can we prevent cancer relapse? So if there is some cancer left behind in the wound, can the immune cells that come along then kill the remaining cancer cells? But the problem is we don't actually know what is happening when this occurs. And when I first thought of this, I'm like, surely someone has researched into the wound response in cancer. And I scoured all these papers and the internet, and no one has actually looked at how cancer itself responds when surgery is performed. And so part of this is because when a surgeon goes in and removes all the cancer, they don't expect to have left any cancer behind. And it's not like we're going to go to a patient, oh, do you mind if we just leave a little bit of cancer behind and we'll come back for it a bit later so we can analyze it? I don't think that's going to go down very well. No, never do that to a patient. No one has actually been able to really answer this question. But we do know relapses occur. And so we do know that there is going to be an interaction with the cancer and that wound healing response. And so ideally, the aim of our lab is to give drugs when we give surgery. So this is going to then allow us to, when the wound is open and the surgeon is in there, he thinks he's removed all the cancer, but just to make sure, put the drug in that location. So then that way the drug is only in that location. And so you're not going to have toxic side effects in the rest of your body. And then that drug is then going to stimulate the immune cells that come in to kind of clean up. And that's our main goal. That's what we're aiming to do. But before we can do that, we need to know what is happening. So the way I do that and find out what's happening and the story that's being told is I look at RNA. So RNA is similar to DNA. So if you think of DNA inside of a cell as a giant cookbook with every single recipe to make every single thing that your cell needs to function, that is your DNA. And then your RNA is what you're going to be making for dinner that night. So RNA is just a scrap piece of paper that you've pulled off the shelf. You've got a pen, you've chosen a recipe, and you've just jotted it down. So you're not going to keep this scrap piece of paper. That's just for dinner that night. And then you're going to follow that recipe to make whatever dish that you wanted to make. So on the cell level, this would be DNA is the cookbook, RNA is the recipe that you've written down, so that's what you want to make. And then once you've made it, that is the protein. So in this case, we have made shortbread cookies. So what we can do is we can look at what RNA is available, and that tells us what is being cooked in the cell at that moment. So if we look at DNA, DNA will tell us everything that the cell can make, and that's not really helpful if we want to know what's happening at that moment. So DNA can tell between individuals. So if I was doing a DNA test to see if they have the same DNA, that's helpful then. Or if I want to see if there's any mutations in the DNA for cancer, I can see that there. But it doesn't actually tell me the difference between two cells. RNA, on the other hand, tells me what's happening. And I can also look on the protein level, but then it gets a bit messy because proteins hang around for a long time. So that protein may be from last week, last month, or this morning. I'm not sure. But RNA only is there for a couple of hours or a couple of days and max, and therefore I get a nice snapshot of what's happening inside that cell. So then I can look at all the RNA, and I can see what's being cooked and what's happening in each cell. And what this tells us is what cells are doing to communicate. So cells can't actually talk to each other. So to communicate, they have to make proteins. And so if they want to do a task or they want to talk to the cell next to them, they make a protein. And before they make their protein, of course, they would have to make the RNA. So what I can do is collect all that RNA. So, for example, if my tumor was this bowl of fruit, I can then, what I do is I extract the RNA and I get what I call bulk RNA, and then I read out the recipes. So, so what I'll do is I'll get the tumor sample. Sounds a bit gross, but essentially I do make a kind of a smoothie, and then I extract out the RNA. So then I can see what is happening over time inside the cancer. And so this is what I've found. So this graph is a little bit hard to read, but if we're following the line across, if something goes up, that's a gene being switched on. And if a line goes down, that's a gene being switched off. So that's in comparison to the 0 here, the baseline. So I can see that if we just have a tumor and we just look at that tumor over time without surgery, we can see that not much changes over the 7 days. However, if we do surgery and then we look 1 or 3 days later, we can see all of these genes being switched on and then they're switched off again. So what does this mean? So these genes that are being switched on are my immune cells coming in, and they're also related to the defense response. So they're stimulated, they're angry. It also tells us that there is a window of opportunity here. So we can see that they also then get switched off a week later. So that's telling us that we only have a few days where this response is really loud and we have lots of immune cells in there. So this is important because this immune stimulation is important for response to immune therapies as well. So this gives us an idea that perhaps in this window of opportunity, this is where we should be giving our immune therapies. So to give a bit of a closer look, we also have some new technologies. So if we think of the tumor, like this bowl of fruit, bulk RNA sequencing, kind of like getting all the fruit and putting it in a smoothie and taking out the RNA. We also have technology which is known as single cell RNA sequencing. So this allows me to take cell by cell and then have the RNA out of each one of those cells. And so this allows me to not only see what's being made, but I can then pinpoint it to the cell that is doing it. So I can tell if it's a cancer cell making that noise or if it's an immune cell making that noise. And then there's a brand new technology that's only recently come out and all our scientists are very, very excited about. And that's called spatial sequencing. And this is essentially like a microscope slide, a slice of the tumor, and then we can read the RNAs in that area. So I've then been lucky enough to use some of this brand new technology. So for the single cell RNA sequencing, I've then taken the tumor out, either with no surgery or a day after surgery, and then taken the cells out and then looked at what RNA they express. And I get something that kind of looks like this. And basically every single one of those dots is one cell. And each one of those cells has hundreds of RNAs. So there's a lot of data here. And cells that are more similar to each other are going to be the same color. But basically what I can see is if I compare this no surgery group to this surgery group, is we get all of these in cells here, here, and here coming in that weren't there before. So these are the ones that are coming in and they're bringing this immune response with them. So these are the cells that I'm going to be targeting to try to get them to kill the cancer cells. And the other technology that I've been using, the spatial transcriptomics, where I take slices. I also want to see where these immune cells are. I want to see, are these immune cells getting right into the tumor, or are they just kind of hanging out around the edges? So this is what a microscope slide of the tumor looks like. So this big dark area is quite dense. This is the tumour, whilst this area here around it is the skin. So this tumour is sitting in the upper layer of the skin. And then this is a tumour where half of the cancer has been removed and the rest remains. So I have my skin along the top still, and I still have half of the tumour there, but this half has been taken out and is now being infiltrated with immune cells and wound healing responses. So it's growing new tissue in this area. So with the spatial RNA sequencing, I like to call it Google Maps for cancer. So it tells me where things are. So what I can see is where my cancer cells are. So ones that light up, this red to orange colour, means that they're got lots of RNA, which corresponds to the cancer. So I can see, yes, that's where it's supposed to be. And I can see that, yes, my cancer is still here. But then I can also see the immune cells. So where are my immune cells? So I can see that in a cancer that hasn't had any surgery, there's not that many immune cells in there. However, after surgery, we see these heaps of immune cells coming in here, and they're kind of circling all the way around the cancer and actually going into the cancer as well. So this is very, very promising that these immune cells are not only going in there to hang out to kill bacteria, but they're also kind of sussing out the cancer as well while they're there. So what does this mean? So ultimately, this means hopefully my theory is correct, and we can use the wound healing response to stimulate an anti-cancer immune response. But what it most importantly means is that we have this very small window of opportunity. So it turned out that 1 to 3 days after the surgery was prime time for those immune cells. So this is when the immune cells are coming into the tumour. And so my next theory is that this is when our doctors should be giving immune therapies. And this is where we'll be targeting our immune therapies in the lab and trying to find which therapies best stimulate those immune cells. And not only do we want to stimulate those immune cells, we want to stimulate them in the right way that they actually go on to kill the cancer cells. And ultimately, what we're planning to do is make a material that we can leave behind in the wound that will then slowly release this drug. And I have some very exciting news. We are fast tracking this into clinical trials in pet dogs. So sarcoma is unfortunately quite common in pet dogs and cats. And really there's no therapies available to pets. It's a bit cruel to make them undergo rounds of chemotherapy, and we don't have any radiotherapy equipment here for pets in WA, so you'll have to fly them over to Melbourne. So we're starting a trial where we have developed a biomaterial. So this is something that holds the drug, and we put inside it an immune stimulant, so something that's going to activate the immune response. And so we recruited some doggy patients, and so when they undergo surgery to remove their sarcoma, they're going to, the patients, well, I should say the dog's owners have the choice if they want their dog to receive this experimental therapy, and we'll then leave that in the wound, and then that will release the drug. And so from this trial, we'll be able to see if the cancer does grow back, and if it, or if it grows back less. And we can also be able to track the immune response. So is their immune system doing what we want to do? So this is a very, very early trial. It's only going to be in a limited number of dogs, and if that's successful, we will expand it. But essentially what we hope this will do is, if we can get this therapy to work kind of like in a, not quite the clinical setting, but one of the closest things we can get to real life sarcoma in a patient, that will give us really promising results to then move it on to patients. So real people, not dogs in the hospital. So with that, I'm going to end my talk today. A big thank you to the whole sarcoma team. So of this team, there's me, obviously, and here's Brianna, who are driving this project that I've talked to you about. And then we also have Ben Yost, who's been getting blood samples from the dogs to then start this dog trial. And we also have Francois Tao, who's been working on what drugs we should be putting into this material. And Francois has been working really hard on developing this material for use. And of course, a big thank you to the people who sponsor and our research or have given us grants. Most of the research I've presented today has been funded by the Cancer Council of WA. Also, SOCA2 Sarcoma have been really great help. And then others have supported me in my fellowship, such as the Forest Foundation, and a few others, such as the CCLRF and the Lions Cancer Foundation, and as well as UWA and the Australian Government. All right, so thank you, everyone. I hope you enjoyed the talk today. And if you have any questions, you can type them into the chat box. Thank you.
Thanks so much, Rachel. I really enjoyed your talk tonight. It was really interesting to me, particularly the little sound of the dog barking just as an throughout the talk. Spoke about involvement. Yeah. As you spoke about your current research now involving dogs, I thought that was neat. As Rachel said, please include any questions that you have, and I'll be able to ask them to Rachel. Rachel, what I found with your talk is that you were able to distill the information in a way that I just found, that you were able to talk about something so complex in a way that I could understand. So I really appreciate that. But I'm not sure I'll be able to think of my recipe books in quite the same way now, seeing the way that you've done that. I have a question for you, and you did mention that Cancer Council has funded some of your research, and as you know, Cancer Council, that all researchers that apply for our funding must show that they include community people or consumer representatives in their projects, so that researchers are involving the people their research is intending to benefit. And Rachel, I'm wondering if you could talk to us a little about how you involve community members or consumers in your research projects.
Really, this whole project kind of stemmed from talks with community and consumers, the consumers mainly being surgeons for sarcoma. So when we first started this lab, we started talking to people who knew best, and one thing that surgeons brought up, and also the consumers and community members brought up, is that fear that the cancer is going to come back, and that's a very, very real fear with sarcoma. And so for the surgeons, they kind of had this bit of a throwaway line where they'll be like, well, wouldn't it be great if I could just be sure, or I could do something to make sure it didn't come back? And so that's kind of snowballed to this whole lab growing from that idea. And we've had talks with a few community members who also have had very severe side effects from the high dose chemotherapy. And they say, well, wouldn't it be better if you didn't need all this chemotherapy? So they've done the surgery, the tumor should all be gone, but they still have this very high dose chemotherapy. And then those patients have then gone on to either need a heart transplant or have developed a leukemia as a secondary cancer because of the chemotherapy. And so we've had a lot of discussions with them, and kind of came up with the idea that maybe it'd be good to put something in the wound during surgery, because in that way it's localized, we don't have the systemic effects, and the patient doesn't have to keep coming in for treatments. So we had that with the patient in mind. So if we could put it into the wound during surgery, they wouldn't have to keep coming back.
Thanks so much, Rachel. I've got a comment, but not a question from Hassan,
Yes.
just saying thank you for the excellent presentation. So thanks very much, Hassan.
Thank you.
I have just one more question then. Just the technique you're talking about I was wondering if the technique has been used in any other cancer types that you talked about, that immunotherapy after surgery. Has it been used in other cancer types?
No, so at the moment, if patients going to receive immunotherapy, it's usually not considered at all when the surgery is in relation to that. So it will either be as soon as they can, or they may be on chemotherapy, so they might wait for their blood cell count to come back up and their immune response to come back up and then give the immunotherapy. And it's not considered at all that this actually may be quite crucial timing to give the best result.
Sorry, Rachel. Thanks very much for that answer. Simon's asking, what is the timeline on the dog trial?
Not 100% sure, but we do have recruitments. Sorry, my dog's going off in the background. I think the first patient might be getting treatment next week, so very soon. And we've just got a little bit more money to fund that trial. And then we'll be recruiting more dogs over the next 6 months. And then after that, we'll then go on to a larger trial.
That's really interesting. And I'm sorry if you mentioned this before, but is it considered that the way that the dogs respond, is that a similar way that people respond to immunotherapy also?
We don't really know how similar it will be, but what is really similar is the cancer. The sarcoma that arises in the dogs is very, very similar to what arises in people.
Thanks so much, Rachel. There's one more question. With this trial, would this mean that radiation therapy isn't particularly needed?
That's a very, very good question. No, what we are finding is that things like chemotherapy and radiotherapy can actually enhance the effects of immunotherapy. And how that works is because the chemotherapy and radiotherapy kill the cancer cells, kind of releases anything that's inside the cancer cells when they die. And then that also causes immune cells to go to that site. And because the cancer cells have then died and released everything inside, it allows the immune cells to actually see all those mutations a lot better. And so if you combine immunotherapy with chemotherapy or radiotherapy, you can get a better result. It also helps because if you shrink the tumour down, so if they have chemotherapy or radiotherapy and they see shrinkage of the tumour, it means that it's going to be less work for your immune system to do. So one of the problems that immunotherapy has is the immune system gets exhausted if there's a really big tumour. So if the tumour is smaller, it will help as well.
Thanks so much, Rachel. Look, I'm not seeing any more questions come, and just given the time of night, I might end the questions there. Rachel, I would like to thank you again for sharing your valuable time with us all. It's been so interesting to hear about your cutting edge research, and I'm just, it makes me feel very proud to be part of the WA community where these things are taking place. I'd also like to thank everyone for joining us today. I mentioned before that we will be emailing out an online evaluation form, and I do encourage you all to complete this, please, to help us plan for future events. But at that point, I just say thank you, and there's lots of thanks coming through from the people joining us today. But thank you, and I hope that you all have a lovely evening.
Thank you, everyone. Tilly apologises.
Oh, no.
For
It was wonderful.
Enjoy the rest of your night, everyone.
Thank you.